This content is AI generated for informational purposes only and should not be directly used for clinical decision-making.
Hello, and welcome back to the Neurosurgery Hub podcast. I'm Dr. Aris, Senior Attending Neurosurgeon.
And I'm Dr. Alara, Research Fellow. Today we're looking at a fascinating new study from Japan, published in PloS 1 in 2026. It's a protocol for a multicenter, non-inferiority randomized controlled trial that tackles a very practical question in our field: the best way to secure the lamina during a double-door laminoplasty.
This is a classic bread-and-butter neurosurgery topic, Alara, but with a modern twist. For our listeners who are residents or students, we're talking about degenerative cervical myelopathy, or DCM. This encompasses cervical spondylotic myelopathy, CSM, and ossification of the posterior longitudinal ligament, which we know as OPLL.
Exactly. And as we know, cervical laminoplasty, or LAMP, is essentially the gold standard for these patients, provided they don't have significant kyphotic deformity or major anterior cord compression. The goal is to preserve the posterior elements while achieving decompression. But the big technical hurdle has always been lamina closure.
Right. If that opened lamina closes back up, you lose the decompression, and the patient can suffer neurological deterioration or kyphotic changes. Historically, we used the technique described by Kurita and Miyazaki back in the day, double-door lamp using stay sutures. But since then, the industry has given us a lot of toys: hydroxyapatite spacers, mini plates, and now these clip plates.
And that's what this trial, led by Kentaro Yamada and his colleagues at the Institute of Science Tokyo, is investigating. They are comparing the modern clip plate system against a suture-anchor method.
It's an interesting comparison. Let's talk about the clip plates first. The paper mentions they offer a 1.5 to 2.0-fold increase in biomechanical strength compared to traditional hydroxyapatite spacers. They are rigid, they are durable, and they've become very popular. But they aren't perfect, are they?
No, they aren't. The authors point out that even with mini-plate systems, you still see lamina closure in about 3.4% to 13.4% of cases. This usually happens because of screw dislodgement or, more commonly, a hinge fracture. Plus, there's the cost factor. These plates are expensive, and the placement can be time-consuming.
Which brings us to the experimental arm of the study, the Suture-Anchor. This is a bit of a simplified approach, isn't it?
It is. Instead of a bulky plate and screws, you're embedding an anchor into the lateral mass. The paper notes that a pilot study using intraoperative CT showed that these suture anchors maintained laminar expansion more rigidly than traditional stay sutures, and biomechanically, they've been shown to be sufficiently tolerable.
So the core question of this RCT is whether the suture anchor, which is potentially cheaper and easier to use, is non-inferior to the rigid clip plate. They aren't trying to prove it's better necessarily, just that it's just as good in terms of patient recovery.
Exactly. It's an open-label, multi-center trial involving 3 high-volume spine centers in Japan. They're aiming for a total of 216 patients, randomized 1-to-1.
Let's dive into the specifics of the protocol. Who exactly are they enrolling?
They're looking for patients with DCM, so CSM or OPLL, who are scheduled for double-door laminoplasty at levels ranging from C3 to C7. The key is that these patients have symptoms of myelopathy and MRI evidence of spinal cord compression. They are excluding anyone with a history of cervical spine surgery, significant trauma, or those with a cervical kyphosis angle of more than 10 degrees, as those patients usually need an anterior or a combined approach.
That makes sense. Keep the cohort clean. Now, the primary endpoint is something every board-certified surgeon knows: the JOA score.
Yes, specifically the recovery rate of the Japanese Orthopedic Association score at 1 year postoperatively. They're using the standard formula to calculate that recovery percentage. It's the most established way to measure neurological improvement in this population.
But for those of us in the OR, the secondary endpoints are just as interesting. They're looking at operative time and blood loss. If the suture anchor is significantly faster, that's a major win for hospital efficiency and patient safety.
Definitely. And they are also looking at direct medical costs. In an era where healthcare economics is becoming a central pillar of surgical planning, if we can show that a less expensive device provides the same clinical outcome, it changes the conversation.
I noticed they are also getting quite deep into the radiological outcomes. Talk to me about the laminar retention rate.
That's one of the most critical parts of the protocol. They'll be using CT scans to measure the distance between the split spinous processes. By comparing the distance immediately after surgery to the distance at 1 year, they can calculate how much, if any, the doors have closed. They're also looking for hinge fractures and bone union at the hinge site.
Hinge fractures are the bane of a good laminoplasty. If you crack that hinge too far, the whole structure becomes unstable. The paper mentions that screw dislodgement in plate systems can actually cause these issues. I'm curious to see if the flexibility of a suture anchor might actually be more forgiving than a rigid plate.
That's a great point. The biomechanical strength of the plate is a double-edged sword. If it's too rigid, all that force goes straight into the bone-screw interface or the hinge itself. The suture anchor might distribute that tension differently.
And what about the MRI findings?
They're looking at the cross-sectional area of the spinal cord and the expansion rate of the spinal canal. It's one thing to see the bone stay open on a CT, but we need to see that the cord actually has more room and that we've achieved the intended decompression.
Let's talk logistics. How are they ensuring this study is robust?
Well, it's registered with the Japan Registry of Clinical Trials, JRCT. They've got a very clear randomization process using a web-based system to maintain concealment. Since it's a surgical trial, it's open label. You obviously can't blind the surgeon to whether they are putting in a plate or an anchor, but the primary outcome, the JOA score, is a standardized clinical assessment.
And the non-inferiority margin? That's always the sticking point in these trials.
They've set the non-inferiority margin for the JOA recovery rate at 10%. If the Suture-Anchor group stays within 10% of the clip plate group's recovery rate, it will be considered non-inferior. Based on their power calculations, with a 10% dropout rate, they arrived at that 216 patient sample size.
It's a rigorous setup. They are also including patient-reported outcomes, right? EQ5D5L, the Neck Disability Index, and VAS for neck pain.
Exactly. We often focus so much on the cord decompression that we forget about the axial symptoms, the chronic neck pain that can follow laminoplasty. The study wants to see if one method leads to more postoperative neck pain than the other. Some argue that bulkier implants, like the mini plates, might contribute to more soft tissue irritation or persistent pain.
Right. The suture anchor is much more low profile. You're embedding it into the lateral mass, so there's less metal sitting in the posterior compartment. If that correlates to a lower NDI or VAS score, that's a significant clinical finding for our patients.
The authors conclude by stating their hypothesis that the suture anchor technique will be non-inferior in both neurological recovery and laminar stability. They really want to establish high-level evidence for a strategy that maintains standards but reduces costs.
It's an important goal. As a senior attending, I've seen techniques come and go. We often gravitate towards the strongest or most rigid fixation because it feels safer in the OR. But if a simpler, cheaper method like the suture anchor provides the same one-year recovery and keeps the lamina open, we have to ask ourselves why we're using the more complex system.
And for residents and fellows, this highlights the importance of looking at the protocol level of a study. Seeing how they define lamina closure or how they plan to measure bone union at the hinge is just as important as the final results.
Absolutely. It's about the rigid posterior neural arch. That's the phrase the authors use. Whether you use a clip plate or a suture anchor, the biological goal remains the same: bony fusion at the hinge or split spinous process to keep that canal open forever.
This trial should definitely provide some clarity once the results are in. It's a multi-year project with the protocol being published now and data collection ongoing at those high-volume centers.
Well, Ilara, this has been a great dive into a very practical piece of neurosurgical research. It's not always about a brand new, flashy technology. Sometimes it's about refining what we already do to make it more efficient and cost-effective.
Totally agree. I'll be keeping an eye out for the follow-up data on those JOA recovery rates.
As will I. That's all the time we have for today's episode of the Neurosurgery Hub podcast. I'm Dr. Aris.
And I'm Dr. Ilara.
Join us next time as we continue to explore the latest evidence shaping our surgical practice. Safe operating, everyone.